IBS, expanded with medical and nursing details suitable for academic or clinical submission. Irritable Bowel Syndrome, IBS. Introduction. Irritable bowel syndrome, IBS, is one of the most common functional gastrointestinal disorders encountered in both general and specialized medical practice. It is characterized by chronic, recurrent abdominal discomfort or pain associated with altered bowel habits, such as diarrhea, constipation, or both, without any detectable structural or biochemical abnormalities of the gastrointestinal tract. IBS is not life-threatening, but it can cause significant distress, impair daily functioning, and reduce quality of life. The condition is influenced by multiple factors, including diet, psychological stress, and disturbances in gut motility and sensitivity. The complex interaction between the brain and gut-brain axis, plays a central role in the pathophysiology of IBS. Definition. According to Rome 4 Diagnostic Criteria, 2016, IBS is defined as a functional bowel disorder in which recurrent abdominal pain, on average, occurs at least 1 day per week in the last 3 months and is associated with 2 or more of the following. Related to defecation, pain may improve or worsen after bowel movement. Associated with a change in stool frequency. Associated with a change in stool form, appearance. The onset of symptoms should occur at least 6 months before diagnosis. 3. Etymology. The word irritable refers to the increased sensitivity or overresponsiveness of the intestines to stimuli. Bowel refers to the intestine, small and large. Syndrome signifies a group of symptoms that occur together but do not necessarily have a single known cause. The term irritable bowel syndrome was first introduced in the 1940s to describe patients who had abdominal symptoms without any organic disease. Epidemiology. Global prevalence affects approximately 10-15% of the world population. Gender distribution. More common in females than males, 2:1 ratio. Age group typically begins in early adulthood, 20 to 40 years. Geographic pattern. More prevalent in Western and industrialized nations, but incidence is increasing worldwide. Healthcare impact. IBS accounts for up to 30 to 50% of gastroenterology referrals. Quality of life. Patients often report impaired productivity, fatigue, and psychological distress. Number 5, types of IBS. According to Rome 4 classification, IBS is categorized based on the predominant stool pattern. 1. IBS-C, constipation predominant, hard or lumpy stools in more than 25% of bowel movements, loose stools in less than 25%. 2. IBS-D, diarrhea predominant, loose or watery stools in more than 25% of bowel movements, hard stools in less than 25%. 3. IBS-M, mixed type, both hard and loose stools present in more than 25% of bowel movements. 4. IBS-U, unclassified, insufficient abnormality to fit into other categories. Causes. The exact cause of IBS remains unclear, but it is multifactorial, involving the following mechanisms. Altered gastrointestinal motility, either hypermotility or hypomotility, leads to diarrhea or constipation. Visceral hypersensitivity. Increased sensitivity of intestinal nerves causes exaggerated pain from normal bowel movements. Post-infectious changes. IBS can develop after a gastrointestinal infection, post-infectious IBS. Microbiome imbalance. Altered gut flora affects digestion and immunity. Brain-gut axis dysfunction. Miscommunication between the brain and intestines due to neurotransmitter imbalance, serotonin, norepinephrine. Psychological factors. Stress, anxiety, and depression worsen symptoms. Dietary factors, food intolerances, e.g. lactose, gluten, FODMAPs, can trigger symptoms. Hormonal influences, many women report symptom exacerbation during menstruation. 7. Risk factors, female gender, family history of IBS, history of acute gastroenteritis, psychological stress or trauma, depression or anxiety, sedentary lifestyle, poor dietary habits, high fat, low fiber, food allergies or intolerances, sleep disturbances. 8. Complications. While IBS does not cause structural or biochemical damage to the intestines, it can result in several secondary complications: chronic abdominal pain and discomfort, dehydration in IBS-D due to diarrhea, nutritional deficiencies due to food avoidance, reduced work performance and absenteeism, sleep disturbances and chronic fatigue, anxiety and depression, reduced quality of life, increased healthcare costs due to repeated medical visits. Number 9. Pathophysiology. The pathophysiology of IBS involves a complex interplay of biological, psychological, and social factors. 1. Altered motility. Increased or decreased intestinal contractions lead to diarrhea or constipation. 2. Visceral hypersensitivity. Enhanced perception of intestinal distension causes pain. 3. Brain-gut axis dysregulation. The enteric nervous system and central nervous system have disrupted communication. 4. Microbiota alteration, dysbiosis, imbalance of gut bacteria, contributes to inflammation and bloating. 5. Immune activation, low-grade mucosal inflammation with increased mast cells and cytokines. 6. Serotonin imbalance, altered serotonin signaling affects bowel movement and pain sensation. 7. Psychological factors. Emotional stress triggers autonomic changes in gut motility and sensitivity. Number 10. Stages. IBS does not have traditional stages like cancer, but the clinical course can be divided as follows. 1. Onset stage. Initial appearance of symptoms, bloating, cramps, irregular bowel habits. 2. Recurrent stage. Fluctuating episodes often triggered by diet or stress. 3. Chronic stage. Persistent symptoms requiring continuous lifestyle and medical management. 4. Remission stage. Periods of symptom relief between episodes. 11. Signs and symptoms. Gastrointestinal. Abdominal pain or cramping, often relieved after defecation. Bloating and abdominal distension. Altered stool frequency, diarrhea or constipation. Mucus in stool. Feeling of incomplete evacuation, flatulence and urgency. Non-gastrointestinal. Fatigue and sleep problems, headaches, back pain, anxiety or depression, nausea after eating. Number 12. Medical diagnosis. Diagnostic criteria, Rome of 4 criteria as previously stated. Laboratory and imaging investigations to exclude organic causes. Complete blood count, CBC, to rule out infection or anemia. Thyroid function tests to exclude hypothyroidism, hyperthyroidism. Stool examination for infection, occult blood, or parasites. Celiac disease antibody tests, TTG, EMA. Colonoscopy or sigmoidoscopy to rule out malignancy or inflammatory bowel disease, IBD. Lactose intolerance or hydrogen breath test. Number 13. Nursing diagnosis 1. Altered bowel elimination pattern related to intestinal dysfunction. 2. Acute pain related to increased intestinal motility. 3. Imbalanced nutrition, less than body requirements related to altered absorption or dietary restrictions. 4. Anxiety related to chronic symptoms and fear of attacks. 5. Deficient knowledge regarding disease condition and management strategies. Number 14. Medical management treatment is symptom-based and tailored to IBS subtype. Antispasmodics, dicyclomine, hyoscine butyl bromide, relieve abdominal cramping. Antidiarrheals, the loperamide, cholestyramine, control diarrhea. Laxatives, IBS-C, lactulose, polyethylene glycol, ease constipation. Antidepressants, tricyclic antidepressants, amitriptyline or SSRIs, fluoxetine, modulate pain and stress. Probiotics, improve gut flora. Antibiotics, rifaximin for IBS-D. Peppermint oil, natural smooth muscle relaxant. 15. Nursing management, assessment. Monitor bowel habits, pain, dietary intake, and emotional state. Education. Explain disease nature, functional, not structural, stress role, and diet modification. Dietary care. Encourage small, frequent meals, avoid caffeine, alcohol, and gas-forming foods. Stress management. Promote relaxation, breathing exercises, or yoga. Fluid and fiber. Encourage adequate hydration and soluble fiber intake, psyllium. Medication adherence. Ensure regular intake of prescribed medicines. Psychological support. Encourage coping strategies and provide reassurance. Number 16. Treatment options. 1. Lifestyle modification. Regular meals, adequate hydration, exercise, and sleep hygiene. 2. Dietary therapy. Low FODMAP diet, reducing fermentable carbohydrates, avoidance of lactose, caffeine, and fatty foods. 3. Pharmacologic treatment, based on IBS subtype. 4. Behavioral therapy, CBT, hypnotherapy, or mindfulness-based stress reduction. 5. Complementary therapy, acupuncture, herbal remedies, probiotics, yoga. Number 17. 5 psychosocial interventions. 1. Cognitive behavioral therapy, CBT, helps identify and change negative thought patterns contributing to stress and symptoms. 2. Mindfulness-based stress reduction, MBSR, teaches meditation and relaxation to improve stress control and gut function. 3. Relaxation techniques, deep breathing, guided imagery, or progressive muscle relaxation. 4. Support groups, sharing experiences and coping strategies reduces isolation. 5. Psychotherapy counseling, helps patients manage anxiety, depression, and psychosomatic responses. 18. Prevention. Eat a balanced, fiber-rich diet. Avoid known trigger foods, spicy, fatty, or processed foods. Manage stress through yoga, meditation, or counseling. Drink plenty of fluids daily. Exercise regularly to improve bowel motility. Avoid excessive caffeine, alcohol, and nicotine. Maintain regular sleep and meal schedules. 19. Conclusion: irritable bowel syndrome is a chronic, functional disorder that significantly affects a person's physical and emotional well-being. Although it does not lead to severe complications or mortality, its symptoms can be debilitating. Effective management requires a multidisciplinary approach involving diet modification, stress management, patient education, and medical therapy. Nursing care plays a crucial role in promoting lifestyle adjustments, providing emotional support, and enhancing patient compliance. With proper management and awareness, individuals with IBS can lead normal and productive lives. Thank you. Have a nice day.